You're live. All right, good morning. So we are back. This is Senate Health and Welfare. It's still February 4th, and we have moved on to S64, a bill that we began last week, and it's an act relating to the amendment of scope of practice for optometrists. And we have Dr. Jessica McNally. There you are.
I'm right
Here,
here.
please come right up here into the seat, and
I didn't.
we
You did it now. I know.
we tried to expand the
almost texted you.
Jessica is my neighbor, full disclosure. So I'll excuse that. Okay, yeah, we have about an hour. We might be able to do a little bit more with it. So we'll just see what we got to. This isn't the last time we'll be looking at this bill, so I know that many of you will be back again. Okay, well, welcome for the record.
For the record, my name is Jessica McNally, and I'm an ophthalmologist and current president of the Vermont Ophthalmological Society. I just want to make sure everyone knows that I will be splitting my testimony. So at the end, after we're getting to the end, I'm going to be bringing in some visual aids in the video, so folks will kind of understand what we do. Because I think that's probably one of the parts of the kind of legislation that's often. Caroline, thank you for allowing me to testify on behalf of Vermont ophthalmologists to voice our concerns about S64, a bill that would expand the scope of practice of Vermont optometrists to include eye surgery. To be clear, the singular goal of Vermont ophthalmologists is to ensure that Vermonters receive safe, high-quality surgical eye care. With that in mind, we have great concerns about this bill and its implications. In the close to 20 years that I've been in practice, I have seen firsthand the confusion about the difference between an ophthalmologist and an optometrist. In fact, a 2018 survey conducted by the American Medical Association found that over half of respondents either did not know or were not sure if an optometrist was a physician. All ophthalmologists are physicians and surgeons. As you will hear, ophthalmologists complete a 4-year undergraduate bachelor's degree program, after which they complete 4 years of medical school identical to other physicians and surgeons. After completing medical school, ophthalmologists move on to obtain 4 to 6 more years of residency and fellowship training. All ophthalmology residency programs are standardized across the country and must meet rigorous National Accreditation Council for Graduate Medical Education requirements, called ACGME. As in all surgical residencies, ophthalmologists are held to the highest standard of care and do not graduate from their program until they have proven competency, not simply by numbers of surgeries performed or passing board examination, but by meticulous formal assessments by our mentors. These include elements such as working cohesively with colleagues, professionalism, patient relationships, and surgical skills and progression. Each member of residency program clinical competency committees must agree that a resident has attained competency before the resident is allowed to graduate. Optometrists also complete a 4-year undergraduate bachelor's degree program. They then attend a 4-year optometric program and have the option of completing additional training after that. This additional training is not required to obtain a Doctor of Optometry degree. In the materials by the optometrist in the OPR report, they have provided examples of such additional training and that are given, such as low vision, contact lenses, and oculars. What we and what OPR found is that in a 4-year optometric program, there are didactics, for example, lectures and videos, along with laboratory simulations and surgeries on model eyes and model skin. The standardization of hours, numbers of hours of didactics, and numbers of simulations performed is not clear to us from one optometry program to another. What is clear, and what OPR has found, is that the majority of optometry schools, in that majority, there's no hands-on surgical training on live human beings. In fact, there were only 2 states out of the 14 that we heard about last week with expanded scope that have optometry schools and that can train their students in all of these surgeries on live human beings. We have observed that the system of licensing optometrists and perform advanced procedures is starting to develop cracks. Recently, it was revealed that Kentucky allowed 21 optometrists to be licensed without passing all of the required things. A malpractice lawsuit has been filed against one of these optometrists related to use of the laser. Even optometrists have expressed concern about the lack of responsibility by the Kentucky Board of Optometric Examiners. A West Virginia court also recently determined that their board overstepped its bounds, and they voided a rule that allowed optometrists to perform eyelid surgery. The two main arguments that Vermont optometrists have brought forward since beginning their effort to expand scope involve access and cost. Optometrists in Vermont have repeatedly asserted that by allowing scope expansion, access to these surgeries will be improved. In Vermont, we are actually extremely fortunate in that we have enough ophthalmologists to provide all scalpel and laser surgical care in and around the eye. It has been suggested that the absolute numbers of ophthalmologists in Vermont does not reflect access because some of us subspecialize and don't perform these surgeries. The fact is that there are only a handful of ophthalmologists, typically retina specialists, who don't perform these surgeries. Furthermore, a July 2023 article published in the Journal of the American Medical Association showed that in Oklahoma, Kentucky, Louisiana, Arkansas, and Missouri, scope expansion to include lasers did not lead to shorter travel time or improved access. A more recent November 2025 article published in the Journal of the American Medical Association demonstrated that although there has been a decrease in the number of ophthalmologists, they're actually practicing in a greater number of locations. The article further determined that nationwide, driving distances to optometrists and ophthalmologists is similar. We have approximately 33 practicing ophthalmologists in the state. Expecting one to be in every county is unrealistic. It would be like expecting to have a urologist in every county, rather, and then have primary care physicians increase their scope by performing neurological surgery to fill the gap. The 4 eye care providers that were mentioned by Dr. Barstow last Friday all practiced in Washington and Orange County. They were all of retirement age and in solo practice. To expect a young optometrist to come to Vermont and buy such a practice with the expectation of performing laser and scalpel surgeries is completely illogical. Lasers can cost anywhere from $40,000 to $50,000, and buying such a practice would be essentially impossible for a new graduate. And there are no studies showing that optometrists are flocking to areas with increased scope and settling in rural areas. And we continue to have concerns that the primary eye care needs of Vermonters are not being met. According to OPR's website, there have been 31 newly licensed optometrists in Vermont in the last 6 years. So there are optometrists coming to Vermont. But it's still difficult to understand how expanding the workload of an already busy optometric provider to include surgeries could possibly improve access to primary eye care. Another major issue we are seeing is that some of Vermont optometrists have stopped taking vision insurance, leaving patients seek care outside of where they live and work. Indeed, both the 2020 and 2023 reports from OPR conclude that, quote, OPR is unable to determine whether expanding the optometric scope of practice would improve patient access to care. I can assure the committee that if a Vermont patient needs expedited or urgent surgery, our optometrists know that they can reach out to us directly. In fact, many of us have each other's personal phone numbers and email addresses. With regards to cost, many arguments have been put forward by optometry insisting that scope expansion will decrease cost. For example, they propose that scalpel or laser surgery could be performed on the same day as the diagnosis, right in their offices, thus saving the patient unnecessary visits and travel time to a surgeon. This argument does not hold water. All ophthalmologists can cite examples of patients who were sent to them for the surgeries in S64 that after being evaluated were deemed unnecessary or even ill-advised. This in fact decreases costs by avoiding surgery. Furthermore, it is nearly impossible to perform surgery on the same day of patient evaluation because of complicated reimbursement issues and obtaining prior authorizations, which I'm sure this committee has heard about. The 2023 report from OPR invalidates optometry's claims by stating, quote, OPR is unable to determine whether scope expansion would have an impact on costs. Optometrists have repeatedly portrayed ophthalmic lasers as safe and easy. The Vermont Ophthalmological Society firmly disagrees with this characterization. Ophthalmic lasers, as proposed for use inside the eye, are categorically surgical instruments used for altering tissue. Surgical treatment with ophthalmic lasers is not a primary eye care service and should be performed by physicians who are hospital residency trained surgeons. Furthermore, the existing and future laser need eye care of Vermonters do not come close to providing the caseload numbers needed for optometrists to maintain competency. Yesterday, I reviewed the laser data surgery for my own practice, which includes myself and Dr. Young, between September and November of 2025, and have submitted it for your review. It demonstrates that relatively low numbers of lasers performed are compared to the number of actual referring optometry practices and optometrists to the 2 months. And that information is insane. Optometry scope expansion into the scalpel and injection surgery listed in the bill would allow optometrists to remove lesions, which some refer to as lumps and bumps, on the eyelids and around the eye, but without characteristics or obvious signs of malignancy, as is recommended of death. The oculoplastic specialist at UVM, Dr. Liz Poole, has spoken and written at length about how difficult it is to predict a malignant lesion from a non-malignant lesion, and how that even she, an expert, has been surprised with biopsy results. Other challenges in removing lesions from the eyelid involve what happens to the skin after the removal. For example, how the wound is often much larger than expected once it has been cut off. There can be unexpected bleeding that can be anxiety provoking for the surgeon and the patient who's awake. The bill would also allow repair of traumatic eyelid laceration. Anyone who's ever repaired an eyelid laceration knows that even superficial lid lacerations can be extremely complex and is much more difficult than simply surgery or surgical incision. Other proposed surgeries in the bill include corneal cross-linking. There is only one ophthalmologist in Vermont who's trained to perform the surgery, and that is because he is a fellowship-trained cornea specialist. This surgery is outside the scope of practice of all other Vermont ophthalmologists, including myself and the others standing in this room. Our retina surgeons have significant concerns about the inclusion of something called fluorescent angiography in the bill. This is a dye test that looks at the structures in the back of the eye. The dye is injected into a vein, which can also often cause nausea and sometimes even vomiting and potentially anaphylaxis. Our retina specialists maintain that the far majority of retina disease can be diagnosed with other equipment that is already widely available and utilized regularly in almost every optometric practice in the state. Even after hearing all of our concerns about training, risk to patient safety, and finding that there would be no increase in access or cost savings, OPR has concluded that it supports expanding the optometric scope of practice to include proposed advanced procedures, so long as optometrists have the necessary training. So of course, the question then becomes, who decides what that necessary training is? Is it OPR? Is it the Vermont legislature? When OPR, perhaps unfairly, was tasked by the legislators was to create a compromise that would make some people feel better about optometrists performing eye surgery. And to that end, they have created a training program for eye surgery, which they have labeled a preceptorship. Clearly, OPR does not find that current optometric education provides the necessary training to perform these surgeries. Otherwise, they would not have created a surgical training program themselves. We have the utmost respect for OPR and the work we have done on this issue. And we, and a lot of other people, have spent hours with them on this. But they do not have the expertise to make recommendations on the training required to safely perform eye surgery. Once early on, we asked them in one of our meetings, how could you possibly know in any detail about all of the professions you oversee? Because as you know, it is a laundry list of professions. And the answer we received was, we depend on the expert. Our response is that we, as ophthalmologists, are the experts. OPR's proposal to bolster training experience, some of which has been adapted for the bill, falls far short of ensuring safe eye surgery in Vermont. Setting appropriate standards for medical and surgical training should only be done by properly accredited organizations. These organizations should be comprised of individuals with firsthand knowledge and expertise in eye surgery and developing curricula with proven standardization to ensure competency of surgeons and accountability of the accredited body. Safe surgery of Vermonters can only be provided by physicians who have completed medical school and an ACGME accredited ophthalmology residency program. I will close with where I began, that the singular goal of the Vermont Ophthalmological Society is to ensure that Vermonters receive safe, high-quality surgical eye care. As legislators, your ultimate responsibility is to protect the safety and well-being of the people of Vermont. That includes yourselves, that includes everyone in this room. I think we all want safe surgical eye care. Thank you very much.
Thank you. And questions? Thanks for including the references with the links.
I do have a handout here that we couldn't link that shows the optometry schools within the United States and the 2 states that actually obtain or have the schools that can train optometrists to perform these procedures. There's only 2 of them amongst all the black dots. You can see.
Can we?
Yeah, we'll send that to you.
I guess one of the things now I'm struggling with, you hit it at the very end. For me, it's going to be safety, access, and cost. That's just what it has to be. We receive a lot of testimony in here from OPR. Supporting the bill and thinking that it's safe, but you're the experts, like you said. So, if you disagree with OPR's opinion on that, then certainly.
And we do.
Oh, I can tell.
We agree, and I am incredibly sympathetic to OPR. I mean, back when this started, like 7 years ago, I remember sitting with OPR for at least 4 hours. And in that initial bill, we submitted a huge binder of information, including photographs of all of these procedures, those different ACGME requirements. We submitted them for other subspecialties to illustrate how many numbers of procedures are often required by other subspecialties. They have spent hours.
And there's no way you and the optometrist can get together and.
At this point, no. At this point, I think the division between where they are coming from and we are coming from is very far apart.
Because you guys work together.
And that
Law, right? I mean, what I envision, you
Yes.
are in the same field and you work together.
Yeah, in fact, we often are in the same offices, share patients. with
You're not
each
gonna make
other.
this easy, are you?
This is something that's important. It's states for eye surgery.
Go ahead. Thank you. Thanks for your testimony. You made a very good case for the difference in training, and
Yeah.
I totally understand that. Do you have hard, fast data around outcomes that we could look at? Because when I look at the scant information that I have around outcomes, it seems like they're actually pretty similar in terms of procedures that we're talking about with optometrists and ophthalmologists. So can you provide us with data that actually bears out the danger and the poor outcomes that we see with optometrists?
I think the word you used, scant, is actually very applicable in this situation. It is very, very difficult to get data about outcome measures because it's simply not out there.
Well, that's a problem.
Yeah,
by the way.
each state has different self-reporting methods of optometrists reporting complications that they may have had or untoward events. The studies that have been referred to, Dr. Lighthizer study that he referred to on Friday, they actually looked at different countries' data. They looked at the UK, New Zealand, Canada, and the US, and combined all that data. In those countries, optometrists are treated and trained completely differently than here in the United States. It's like looking at apples and oranges. You can't take all of that data, put it together, and make a conclusion about a potential difference in complication rate because the training is completely different.
I guess I just would caution to make claims that you can't back up with actual evidence, because we're trying to make a hard decision here, and I would like to pass evidence.
Yeah, and I wish that they had similar evidence I wish that they had large studies that would show us that, because then maybe we would all feel better about, including optometrists.
Well, the evidence that does exist doesn't show a big difference.
What are you looking
I
at?
can show it to you after I'm on.
Yeah, that'd be good.
Yeah.
I'd love to take a check.
So, one of the concerns I've heard, obviously, is driving times and access in our rural parts of the state, and you've got a reference there that will help us understand that. Appreciate that. Okay, so we have others, and I understand are you gonna come back after?
I'm gonna come back after.
Okay.
Yes.
So we'll move on to Dr. Greenberg, Matthew Greenberg, from the Vermont Board of Medical Practice. And so one of the confusing parts of our lives in here is that the Office of Professional Regulation oversees a great number of healthcare professions, and the Board of Medical Practice oversees another set of professions. So Dr. Greenberg, thank you for being here.
Chair, thank you, committee members, thank you for having me here. First time testifying, I'm nervous. So my name is Matt
Don't
Greenberg.
be nervous. We're all nervous.
Yeah, my name is Matt Greenberg. I'm an emergency physician by training. I have 25 years of experience as an emergency physician. The last 15 of those years has been here in central Vermont. During that time, I take care of a lot of people with eye injuries and eye infections and things like that, but I would not consider myself an eye expert. I would say that in those 25 years, I've learned to respect the eye with respect it greatly. There's a lot that can go wrong when you're messing with the eye. So I do not perform any of these procedures that this bill would afford to optometrists. I just want to make that clear. This is not something that I do. The main reason I'm here, though, is representing the board, the Vermont Board of Medical Practice, which I currently chair. I've been on the board since 2022. We have this material multiple times. Most extensively reviewed it between October 23 and February of 24. That was the time period associated with the OPR report. We gathered the data, we looked at it. We looked at as much data, I think, as you mentioned earlier, there really is a lot of scant data to support this. And as physicians, scientists, we look at data. After looking through that information, we unanimously voted to oppose the expansion of optometry care. We didn't take that lightly. These are our optometry colleagues. We worked with them for various reasons, but we did not feel that the data supported such a significant change from the current standard of practice. And what we looked at was we put the data sort of into three categories. And I think you actually said the same three categories that we were looking at, and that is access, cost, and quality/safety. In regards to access, we actually looked at some of the same studies that were already mentioned. The 2023 study from the Journal of Ophthalmology, which basically looked at several of the states that were early adopters of expanded scope. And it really showed they used distance travel as a surrogate for access, and they didn't show any benefit. I think more importantly, OPR's own report said that they could not justify or they could not show that there would be any improvement in access. Anecdotally, many members of the committee themselves noted that they are already having difficulty accessing their own optometrist waits up to several months. And there was concern that adding additional procedures, perhaps procedures that pay more, reimburse more, would only worsen access to the underlying optometry care. So that was access was one thing. Cost is another thing. We all know that costs in the state of Vermont, healthcare costs are outrageous. We need to figure out ways. And honestly, there's arguments on both sides of this. But I don't think there's a clear winner. And that was what the board felt, was that there was no clear distinction or no clear winner in which would cost more. There is some evidence to suggest that there are increased procedures which would cost increased cost. But the data is just not really there. And again, OPR in their own, very thorough investigations that they were unable to determine if there would be a cost benefit. So taking cost and access out of the picture, we get left with quality. And the main role of the Vermont Board of Medical Practice is the safety, ensuring that Vermont residents get quality, safe, and respectful care. And so this is a really big thing. This is what we spend every month talking about, looking at quality of care. You know, fundamentally, it comes down to numbers. You know, many of the medical quality metrics and companies and, you know, the IOM, all these boards, what they look at for quality in a lot of cases is numbers. And most safety organizations have put out there a minimum number of procedures that need to be done to initiate proficiency and then to maintain proficiency. And what we know from, you know, the training that an ophthalmologist goes through, undergraduate, 4 years of medical school, 4 to 6 years of residency and surgical potential fellowship, they're going to have several hundred of these procedures under the belt. My understanding from the bill itself requires a minimum of 2, which is just not anywhere near what residency trained ophthalmologists would get. And so looking at all of those features together, again, without a clear benefit in access, a clear benefit in cost, and a very large difference in training that runs a high risk of affecting quality, the board felt that they would prefer to stick with the standards that we currently have before expanding scope of practice. That's all I have. If you have any questions, I'm happy to try and answer them.
Questions?
Thank you for your testimony. So OPR, thank you for referencing their study in terms of access and cost. They did make a claim in the study that safety is they feel comfortable with the safety factor. I think that was one of the things that they really dived into in the study. So are you, I guess, disagreeing with OPR?
In that respect, I think the numbers, you know, I've trained residents for many years. You really need to do a lot, whatever procedure you're, again, I don't do these procedures, but I've learned a lot of surgical procedures in my career, and you have to do them regularly, and you need a lot of them under your belt to get that first level of confidence. And from the training programs that we were made aware of, the number just didn't go up. And I think that runs a significant significance.
Other questions? Thank you for being here. And we may have the board back again. I understand whether it's you or David Hurley or whatever, but it's important, I think, that we have some recognition of the board's work in all of this.
Happy to return if you would.
So I won't ask you this question, but it's kind of a general question that keeps resonating with me. So if this is a scope that moves into ophthalmological practices that are currently there, then maybe it should be overseen by the board that currently oversees those practices. So that's another kind of question. So instead of putting something new into OPR, maybe it should be something that's regularly cared for at the board of medical practice. So we'll let that go for now. It's not a question, it's a comment and a rhetorical. Okay. So we'll move on to Dr. Young, who is an ophthalmologist. And then we have a resident from. Thank you for being here.
Thank you. Good morning. I'm Jeffrey Young. I'm a comprehensive ophthalmologist practicing here in the Central Vermont area, just up the road in Berlin for the past 13 years. I've been given the opportunity to share some recent and real experiences from around the state that give me pause when considering the wisdom of passing this bill, S64. These stories, which affected real Vermonters, will illustrate the effect that inadequate training and misjudged confidence can have on real patients. I also want to mention that you have received examples that are included from Kentucky and Oklahoma of similar cases from ophthalmologists that speak to the fact that just because, as has been mentioned prior, that some of these boards have reported no bad outcomes, and that does not necessarily mean that there are no bad outcomes. The state optometry board says that they've never had a reported bad outcome. Or a single complication from a procedure. I think we should all be skeptical. I'm not here to say that optometrists are worse than or better than ophthalmologists, or to say that they are not concerned with patient safety, but to show that comprehensive surgical training, as we've talked about earlier, where we deal with complex and simple cases, is necessary to develop the proper surgical skill and careful surgical judgment, and for the highest standard of safety for all Vermonters. Some of the cases are alarming because the optometrist even mentioned to the patient that they would be performing these procedures in a year, and that the patient could just wait until then, as if passage of this bill was a foregone conclusion. Think of these stories as if this was your neighbor, your friend, or even your family member. The first story, an optometrist who was a recent graduate from an optometry school referred a patient to an ophthalmologist for evaluation of narrow angles, which is a condition that can cause dangerously elevated pressures and result in vision loss or even blindness. The treatment for narrow angles at risk for this condition of angle closure is a laser peripheral iridotomy. This is one of the surgeries being proposed in this bill. Upon examining the patient, the ophthalmologist found that the patient had already had laser peripheral iridotomies, clearly visible on her examination. The patient was sent back to their optometrist without having an unnecessary surgery. This case is concerning to me because the optometrist had apparently been trained in these procedures and had obtained this modern optometric education that has been spoken of. One would assume that this training would allow them to identify whether a procedure had been performed or whether it was even necessary. As a result, the patient was sent for an evaluation, which cost both the patient and the system precious time and money. Now, a second story. An optometrist referred a patient to an ophthalmologist specifically for a glaucoma laser. The patient reported that their optometrist described the laser as simple and that optometrists would be fully trained to perform this laser, or are fully trained to perform this laser, and that they would soon be available in Vermont without referral to an ophthalmologist. The laser referral was made by an optometrist's office as a routine referral, a non-urgent consultation, which scheduled approximately 1 month out. The ophthalmologist reviewed the incoming referral and within 24 hours of receiving it and suspected a more severe condition requiring urgent evaluation and asked the patient to come the same day. The evaluation revealed that the patient had been misdiagnosed and was not a candidate for the referred laser. In fact, the use of this laser would have worsened the underlying condition and likely would have resulted in permanent vision loss. The proper diagnosis was made and the patient was treated appropriately without a laser, and their vision was preserved. This story is another example of a misdiagnosis, an inappropriate treatment plan, and in this case, a delay of treatment. The request for this non-urgent referral put the patient at risk. The laser surgery, which was proposed by the optometrist, was contraindicated. Had it been performed by the referring optometrist in their office, the patient would likely have suffered permanent vision loss. It seems from some of the testimony that have been given in this committee as though simple laser procedures are the answer to everything. Let me say this clearly, they are not. A laser must be treated as any surgery and recommended only when absolutely necessary. And now a third story. An optometrist referred a patient to an ophthalmologist for a YAG capsulotomy, another laser procedure proposed in this bill. Although the patient did have mild posterior capsular opacification or clouding behind the lens implant in both of her eyes, she had no visual complaints. She had no blurred vision with her glasses and no glare. Despite her lack of complaints, she had been referred for this laser surgery. The ophthalmologist who saw the patient felt that proceeding with a YAG capsulotomy in this situation with no medical necessity was contraindicated and therefore did not perform the laser. Furthermore, the ophthalmologist found that the patient's only complaint had to do with dry eye, which was not being treated adequately and can also cause decreased vision. The ophthalmologist felt that withholding an unnecessary surgery and avoiding exposing the patient to undue risk was the most appropriate. This patient was referred for laser surgery that was not medically necessary, and her main complaints were attributable to something that was medically treatable. laser surgery would not have helped in this situation. This case shows that surgical judgment matters, especially knowing when not to do a surgery. Proper training, careful listening, and critical judgment are necessary in surgical decision-making. The best way to protect patients and control healthcare costs is making sure that only those who truly need a surgery receive it. And now a fourth and final story. An ophthalmologist received an urgent referral by an optometrist for a patient who had come to the optometrist with eye redness and vision loss. The optometrist noted a high eye pressure and believed that the patient had narrow angles, which is a condition I mentioned earlier. The optometrist's diagnosis was angle closure glaucoma, which is an emergency, and recommended that the ophthalmologist perform a laser peripheral iridotomy. The ophthalmologist exam showed that the patient's angles were not narrow, but were in fact wide open. The ophthalmologist noted inflammation inside the eye instead. The ophthalmologist did not perform a laser and instead proceeded to investigate the cause for the inflammation. The results revealed that the patient actually had tuberculosis, a rare and serious infectious disease that is even life-threatening. In this story, the optometrist made an incorrect diagnosis in which performing this laser would have A, not improved the pressure or opened the angle, B, would have worsened the underlying inflammation since laser surgery always causes some inflammation, and C, would have greatly confused the entire situation, possibly delaying the true diagnosis. What was needed in this case was identification of the eye inflammation and a search for the cause, which in this case included a medical workup of blood work and a chest x-ray. What makes this case even more concerning is that the referring optometrist had the exact same week published an essay in a prominent Vermont news publication in which they assured lawmakers that optometrists have the proper training and skill to make advanced medical and surgical decisions for care of the eyes. The optometrist's own actions demonstrated that they had significant gaps in expertise that would have harmed the patient and the public. In this case, diagnosis of a deadly disease, tuberculosis, which must, by the way, be reported to the state, would have been missed and an unnecessary laser surgery would have been performed. In each of these cases, the patient was referred for a laser surgery, which, if it had been performed, would have at very least been medically unnecessary and a waste of time and money, and at worst, resulted in blindness. I was only allowed a few minutes here and I've only chosen a few cases. You've received more that have been given to the committee. And these cases demonstrate that proper surgical skill, and more importantly, careful surgical judgment requires comprehensive training, not cursory courses. It requires graded and guided surgical experience, not just fulfilling a checklist. It requires time, not measured in tens of hours, but measured in hundreds of hours, dealing with complexity and complications. Thank you.
So, but Senator, go ahead.
Got a little. I don't want my questions to mean that I've made up my mind on this or that I understand all of this. If I don't, I'm just trying to learn. So that's where these questions are coming from. I'm just curious, do ophthalmologists ever misdiagnose?
Absolutely.
Okay. There are inherent risks in any medical procedure, correct?
Correct.
And LASIK is an example of a procedure that is not necessarily medically necessary, correct?
Correct. It's not being paid for by insurance either.
Right.
It's being paid totally out of pocket, and it's considered cosmetic.
Yeah,
procedure.
I obviously don't have perfect vision. So I asked an ophthalmologist about LASIK, and he actually said to me, don't do it because there is a risk that you could ruin your eyesight. So I'm pointing that out to show that it's just a very nuanced landscape for sure.
It absolutely is nuanced, and that's what I was trying to portray here, that there's a lot of nuance in making a diagnosis. And of course, any diagnosis is something that, is taken seriously. But that the nuance comes in making the diagnosis, and then what do you do after that? I think this speaks to the fact that there is scant data, because these cases, these would not be reported to anybody. These aren't reported to a board as saying, oh, these aren't reported because there's a bad outcome was avoided because something wasn't done. And so I think that these just demonstrate that I think we still need to look at this.
Thank you. And we have Dr. Divi Mera. Mera. Did I say that?
Close.
Is it?
You were right there.
I would, well, why don't you introduce yourself to the
Yeah.
record, we'll get it right.
My name is Divi Mera. I'm one of the fourth year ophthalmology residents at Dartmouth Hitchcock Medical Center. I'm also the current chief ophthalmology resident at the White River Junction VA. Dr. Bill Gensheimer, he's covered me today. But I'm going to expect the post out, so it's sure.
It wasn't a bad drive.
No, it's about hour, 10 minutes, something like that. Yeah.
Oh, I was about the weather.
Oh, yeah.
Lucky.
Started flirting, I think, closer to this area, but not so bad down south. I'm a current surgical trainee, so I just wanted to hope to clarify kind of what my training is entailed and kind of paint a picture as to how this training enables me to be able to perform surgery as best I can. I'm going to try to keep this brief. I have a written testimony that's a little bit more complete, so I encourage you to read that if you have time. So after college, the path to becoming an ophthalmologist begins with 4 years in medical school. I was in Florida at the time, and we also had an optometry school at Nova Southeastern. And so I made quite a few close friends there that are now practicing optometrists. I was just a groomsman at one of their weddings. I don't think that I'm totally unfamiliar or biased to their experience. During my first 2 years, I was inundated with textbook knowledge about how the whole body functions, including how the eyes fit within that system. In the final 2 years, I entered rotations where I worked with hospital teams to treat very sick patients. And I started to perform simple procedures, skin lacerations in the emergency room, assisting in the operating room, things of that ilk, but nothing too serious. Next came residency. I matched at Dartmouth, so I moved to New England to start. We do a general surgery intern year at Dartmouth Hitchcock. And this was intense to say the least, not for the faint of heart. Again, still taking care of very sick patients, but now starting to do much more surgery, particularly, at least for me, it was in the abdomen, the face, the chest, things like hernia repairs, bowel resections, breast cancer, and skin cancer excisions. I wasn't doing eye surgery yet, but I must emphasize that the technical and decision-making skills are foundational for the things that came after. We see the worst complications of our own surgery, and we have to own them. In addition, we learned how to do things like obtain informed consent, discuss risks and benefits, and understand complications firsthand. Only after that did I enter ophthalmology residency, and I started focusing full-time on the eyes. Surgical training is progressive. We start by observing over and over, and then we start doing parts of procedures over and over. And only after proficiency with that are we allowed to operate under supervision and then independent. But even independent, it's still, I can't sign anybody up at the White River Junction VA without Dr. Gensheimer approving it for anything. And he's there in the room for watching anytime I'm doing anything surgical. And as confident as I am in my own abilities, I just have to tell you that this process is painstaking and really, really difficult. And interestingly enough, it is the more involved surgeries like cataract surgery or eyelid surgery that greatly improve my ability to perform clinic procedures. Things like aiming laser at a structure no thicker than a spider web, just microns thick. It's really hard, much harder than it sounds like some people seem to convey to you all. But it's much easier if you've felt and manipulated that structure, unfortunately broken that structure, many times in the operating room. Optometrists also complete 4 years of postgraduate or post-college training. Most are without a doubt excellent clinicians. I grew up seeing an optometrist and credit my interest in ophthalmology to him. But their procedural training seems to be limited to lectures and short workshops or weekend courses, which are helpful introductions, but they lack the realism of live patient care, which takes a long time to develop. Models don't feel pain, move unexpectedly, or bleed. And sometimes what's more challenging than performing the procedure is knowing which procedure to do, when not to intervene, and when you're out of your depth as a clinician. That judgment comes from a wide breadth of surgical experience or clinical experience that I don't even know that I totally have yet. You have to see complications, you have to learn to weigh alternatives under supervision for years from someone smarter and more experienced than you. In residency, I constantly make these decisions and receive direct feedback from my attendings, often in not so nice ways. So why are so many years of training necessary? It's because performing surgery is hard, but knowing how and when to operate is even harder. I think ophthalmologists and optometrists share a common goal. We want to provide high quality, accessible, affordable care to people here. I have very modest views on scope issues generally. I'm a huge proponent of safely increasing access to healthcare, and I've worked on things in the past to do so. But I don't support this bill as written. So I urge you to think kind of long and hard before you change the status quo and change kind of the standard of healthcare, in New England and beyond. But hopefully this bill will spark dialogue and we can all work together to improve the quality of care for all people in New England. Thanks for your time.
Thank you. When do you complete your residency?
I have about 5 minutes left.
5 months left. That must seem like a short time compared to what you go through.
Yeah, it seems like it's
Or an
actually
eternity, depending on. Think about it. Thank you. Thank you very much. And let me ask you one more question while you're here.
Sure.
Where do you intend to practice?
I don't know yet.
You don't know yet.
I'm gonna trust on. I would definitely consider returning to the Dartmouth ecosystem because it's academic, and I'm going to subspecialize in retina surgery, so I will probably never be performing these procedures as a part of my own clinical practice. So I don't have a leg in this game. But I'm going to go to New York for a fellowship for 2 more years. Just keep training.
New York City?
New York City. That'd be fun.
Okay. Well, thank you for this and for the work. Very helpful. All right. So Dr. McNally, we're back to you with the video. And one of the things that's in the bill, you can come up. One of the areas of the bill is sort of blind to us, to use the fund, are all the different procedures that we, fail to know about. I can't even pronounce it right. So we're going to learn how to pronounce them.
And that's, I noticed that even OPR was having trouble pronouncing it the other day.
I noticed that.
Despite the fact that they approved the bill.
Well, it's important that we understand what they are, in the, and I will say that when my husband went through medical school and I used to go to lectures and I was helping out with some areas of in the river. I think that the river had a lot of stuff, but I remember going to the acute glaucoma lectures that was, but I didn't learn how to do the surgery.
That's great. Yeah. Lectures and videos are great, but it takes a little more hands-on to learn how to do things. So I'll show the video first, and then I'll just pass around a few things here so you can get an idea of exactly what is used to train on, and how that might translate into actual practice on a real person.
Any warnings about this video?
Possibly, it's around the eye.
Okay.
It's not of like the internal part of the eye. Okay.
Well, round the eye just as bad.
I know.
I may not watch.
Okay.
I'll listen.
There is a little bit of pleasure, yes. Okay, I guess we look at the screen. So the first video is myself performing a lesion excision.
Well, look at the field of sound.
Sure sound. Is there sound?
I'm not.
Nice.
Yeah, there is.
Okay, opening up. Breath in. Breathe in. Yeah, you go out. Yep, yep. Good job. Breathe again. Breathe out, breathe in. Okay, close. Okay, I think that's it.
Getting a little high.
So that first part was just injecting the light.
Yeah.
You can hear that. And this process of taking off this lesion is
What's the name of this surgery?
So this is the lesion excision. And these are 2 different types of lesions. Both of them are 5 millimeters or less, which is what the bill entails. So it says that they can only take off lesions that are 5 millimeters or less. That one right there is maybe about 3. And you can see that it leaves a pretty large area there. This is cautery.
Oh, okay.
All right.
How about that?
This is not bad.
And you can't hear it, but the cautery is actually making a little buzzing sound. And I do warn patients that they're gonna smell something funny because they
Flesh.
smell their burning flesh.
This-
Yeah, and here I'm just making sure that there's no bleeding. Here's the second lesion I'm taking off, not on the eyelid margin, which is one of the exclusions in the belt.
Can I ask what type of lesions these are?
Again, lid lesion, there's no way to know
Okay.
until these are sent for biopsy.
Left.
I noticed that the individual is still blinking. But the injection was anesthesia.
That's true.
Keep my eyes shut like that.
And here's just suturing the incision.
Search. Do optometrists currently do this?
Oh, no.
The answer is no.
Not in Vermont. Yeah, these are, this is the mismatched 14 states. In one state they do, in another state they don't. In some states they do lasers, in other states they don't. Which kind of, I think, reflects the confusion about,
Is this
The
one
training.
of the? Is this one of the procedures listed in?
this would be an eyelid lesion removal. I don't have the bill right before me.
I got it right there. So it begins on page 3.
And it includes injections, suturing.
Yeah, we got it.
The bill actually specifies those things. And this would be, when I talked about traumatic eyelid lesions or traumatic eyelid lacerations rather, what has been proposed is that sewing up a traumatic eyelid laceration is the same thing as that, which is absolutely not true.
Can you say that again, please?
Yeah, that's sewing up a traumatic eyelid laceration,
Uh-huh.
which is what's in the bill as something that would be allowed, is completely different than sewing up an incision like that. Much more challenging, requiring much more training and understanding of the underlying anatomy. This is a Chalazion excision, which is also in the bill.
Say it again.
Chalazion excision.
Oh, there it is. It's number 8.
This is a type of condition that we typically recommend patients treat with warm compresses for a number of weeks before it gets to the stage where we may or may not provide a surgical option. So again, this is Dr. Hool. She's our oculoplastic specialist. And she has numbed up the patient. Patient's awake. Patient has a surgical cap on. The procedure that I did was required a draping. These are not chair side procedures. Dr. Barcelow referred to these as chair side procedures on Friday. That is not what these are.
Senator do it. This is.
Yeah, don't. Yeah,
So here's the,
like this.
this is where she's using a very sharp blade to cut through the skin. And that's the material inside.
But you-
It's so mean for I thought if I done this with an eyelid or eyeball things, it would be okay. But she's removing the material inside. This is not an infection. But the patient is awake, again, in a special room that we have set up with a bed, a special lamp.
Do they have a choice if they can be awake or?
No,
Is this outpatient surgery?
yeah, this is all within an office setting. But like I said, in a special room on a stretcher, a special kind of stretcher that we call the iBed. Not something I would just lean somebody back in the chair for in an exam room. And then now she's performing some cautery as well.
You doing okay?
Yep.
Senator can probably come back. That's my idea. If somebody wants.
Well,
Yeah. So these are other photos. You saw something like this on Friday with Dr. Lighthizer showing his PowerPoint presentation of what a laser room might look like. This is our laser room in our office. What you didn't see in those photographs that he showed was that there is a danger sign on our door to illustrate to both patients and staff that there's something dangerous going on inside. There is a special kind of fire extinguisher that needs to be used if something were to happen. Anyone who is in the room observing is supposed to be wearing yellow goggles, which are here, and that's to protect their eyes from any of the laser. This is our surgical suite. So you can see there's a special kind of bed, there's a special kind of light. That's an example of the instruments that we might use for certain procedures. And I have these here that I can pass around as well. Different kinds of knives that we use, the cautery, suture material, that sort of thing. Go on. This is the laser capsulotomy, which is also shown in the bill, which you may have seen pictures of, where that bubbly stuff is the film that can develop on the back of the implant lens after cataract surgery. And then the opening that you show is what happens after we use the laser. As Dippy was saying, that's 4 microns thick. It's very, very thin, that part of the eye that we're lasering. So we have to be careful not to make marks in the lens, especially in the center of the lens, that could potentially damage the lens and affect the vision. And then one thing that's not mentioned or specified in the bill, which I find interesting, is that there's no distinguishing between an anterior capsulotomy and a posterior capsulotomy. It just says YAG capsulotomy in the bill. The photo all the way to the right is an anterior capsulotomy involving the anterior part of the capsule, which is a much more difficult procedure to perform. And there's no distinction made in the bill about the difference between the two of them.
Can I ask a question here? Because it's something that Dr. Metry brought up, and that is the need for repetition in doing these, and what is the frequency with which we currently see a need for, don't answer this now, but it would be helpful to know from your experience, the frequency with which you see the need for these particular surgeries within a particular practice. So if repetition is a necessity, then how frequently are we seeing this in an individual practice, and a need sort of, can we predict across the state?
So that is one of the pieces of data that I submitted when I looked at our numbers in my practice between Dr. Young and I. Between September and November of this year, we performed 33 of these between us out of, I believe, about 12 separate optometric practices that refer to us, and perhaps 21 optometrists in those practices.
Okay, so that's a different number. So if you've got 12, how many referral practices?
I think if you count them, I don't recall the exact number. It's been submitted. I think it was 12 optometric practices, but each optometric practice has a different number of optometrists in it. So some have 2, some have 1, some may have 6. So you have to assume that each optometrist is seeing perhaps 10 to 20 patients a day, and they're referring to us for folks who might need, or what they deem are needed procedures.
And so one optometrist in each of those practices capable of performing this, they would get that referral.
It wouldn't even, right, and the numbers don't even match out that each optometrist would even have a referral. Yeah, it would be, yeah, exactly. Thank you for the math. One optometrist, maybe one of these surgeries in a 3-month period, if you actually divided it out.
Okay.
And I think the ratio. Okay, next slide. So this is a laser peripheral iridotomy, which is also listed in the bill. Again, as something that treats narrow angle. That this was noted by Dr. Young in his testimony that about receiving referrals for laser peripheral iridotomies that were not only contraindicated, but also could have caused more problems. So the photo on the right shows the hole at about at the side there where we've actually made the hole. But what the photo on the left shows is what's happening during the time that we're making a hole. The iris itself has blood, it has blood vessels, it has nerve endings, and bleeding can happen, which can make it very difficult to visualize what we're doing. And you really have to know how to take a deep breath and just wait for the bleeding to go away.
I want to insert something here because, I think this is important information for us to know because these are the procedures that we're talking about. That what you're not saying is whether or not someone has the capacity to do the surgery. So I want to clarify because I've heard comments previously that this is all meant to scare us. This is not meant to scare us. This is meant to educate us about what the procedures are and the challenge of doing those procedures, regardless of who's doing it.
Correct.
Now,
This
wanted to clarify that.
This would not be considered a complication. This would never be reported as a complication.
Got it.
This is just part of what can happen when you're doing the surgery. And the more of these you do, the more comfortable you get with seeing the blood and knowing that when the blood goes away, you can continue doing the laser. So that's where that question of volume comes in and training in all aspects of eye surgery. This is an example of an SLT, the selective laser trabeculoplasty that can treat glaucoma. You can see that there's a laser that is directed into the eye, and it's actually lasering a very, very small area right at the very front part of the eye, along this internal drainage system of the eye. So this is basically a microscopic area that we're lasering in this particular circumstance. And then these are injections into the subconjunctival space, which is also listed as something that would be allowed in this legislation. As you can see, the needle comes pretty darn close to the eye, and if the patient were to jump, the needle could go in the eye. And this is that fluorescein angiogram that the retina doctors are very concerned about, where you inject the dye into the vein in an office setting where you can develop anaphylaxis and nausea, vomiting, and which they have told us a number of times is not necessary in the far majority of cases to diagnose Hashimoto's disease. So from the very beginning, I have not, and Vermont ophthalmologists have not understood why this has ever been on the list of something that optometry wants to do, because it's barely done by retina specialists anymore. And this is the final photo. This was corneal cross-linking. Again, this is one of these surgeries that I've never understood why it's been on the list, what the intent is there. Corneal cross-linking is a surgery that generally is paid out of pocket, thousands of dollars. And again, there's only one ophthalmologist in the entire state of Vermont who has the training to do this surgery. This is out of
How frequently is it sought?
Is it rarely. I'm not even sure that our cornea doctor here does it much at all. I've spoken with him about it.
Okay.
It's too expensive. And it's usually done on younger patients as well for this particular corneal abnormality. It's a genetic corneal abnormality. Okay. So this is another thing in the middle. We don't understand what the intent is.
I'm gonna ask you if we can move and close.
Yeah, absolutely.
Just
So
because we're getting close to it. We need to get to our next bill.
if you just pass these around for a second, you can feel,
Okay,
this is what the material is that we actually learned a suture on.
Yeah, okay.
Okay, does not feel like skin at all. These are the eyeballs that are used to train on. And if you really look at it, you can see that there are 4 spots that are already set there. So those 4 spots are locations where an optometrist would be directed to direct the laser. So not taking into account that there are other places of the eye that may be more appropriate to do the laser. So this is basically a practice eye. It doesn't affect the real condition.
Good question. Sure. Thank you for this. Doesn't really mean much to me since I'm not a doctor, but, my question is, it seems as though you have a real, adverse reaction to some of the treatments that are in this bill. If they were removed from the bill, would that make this a little more palatable to the ophthalmologist community?
I think we'd have to have a conversation about which things we're talking about.
Okay.
Well, that's what she's asking.
Yeah,
Yeah.
and that might take some time to sit down and have.
Well, let's see where we get with that one. That's an important question. I think there is a huge interest in having this bill move forward.
I understand that.
There's also a lot, some concerns about the bill that magnify. So having something would be great. And we really appreciate your time and the thought that you've given to this and the information that you brought. It takes away from the practice. We understand that each of you has come in to present. Thank you.
Well, we're happy to do it. Thanks very much.
We may see you again. I understand that. And, you know, when Dr. Greenberg, we said the same thing. So, you know, we like the boots on the ground information, but we also need to have the policy level decision making. Thank you.
I was wondering what that was. And then I saw you. And I was like, oh, okay. Smart.
Thank you, Steph. I'm sure it was fine. This is my daughter. This is like, so.
I don't know. I don't know.
I know.
Oh my God.
Let's see, what is that? Sunscreen? I wonder, are you trying to find out how to
It won't be that.
I'm sorry. To us and answer.
No, no.
Yeah, like. I don't want to bug them. I'd love to.
Yeah, and I don't know when it's quite the nice.
No, I don't.
So when they help bring stuff. These chase, they just, they got a while ago.
Yeah.
I think, yeah.
Oh, let me see.
Would you have a height?
Yeah.
Yeah. Okay.
Was franchise?
Yeah, well, you're gonna be so,
So it's like a C. So they do it in front of,
oh my God.
You're gonna
so
have.
they do it
I would.
right there, so you.
The value.
Is there-
You know what? I wouldn't mind looking at somebody else.
It's just